I would like to say hello. My name is Emma, and I am one of the young adult co-leads, and I will also be your session host for today. It is my privilege to introduce Dr. Sammaritano. Thank you for being with us today at the JA virtual conference. It means so much to us. I would also like to thank our attendees for joining us for our breakout session today. When you get a moment, you can provide feedback on this session by completing the conference survey in the app. This will help us guide programming in the future. And I would also like to note, be sure to come back for our general session on medical transitions this afternoon at 4:15 p.m. You can find the link for the session in the conference app. I would also like to say, don't forget to check out all the kids and teen sessions in the app that can be watched at any time throughout the weekend. Be sure to check the conference app for resources and take part in the JA Insights today. You can access the link in the app. My last reminder for everyone would be to make sure that you keep your microphones muted. Your cameras can be on or off. And if you have questions for our speaker today, you can go ahead and send those directly to Carrie in the chat. We will do our questions and answers at the end. So I'm going to turn it over to Dr. Sammaritano. Thank you.
Thank you. It's really my pleasure to be here today and participate. Thank you to the organizers for inviting me. And I'm going to talk about a topic, let's see. Sorry, I am having trouble moving my slides. I'm going to, maybe this will do it. Nope, I'm going to stop sharing and then go back to sharing and see if that will fix things. Here we go. Okay, let's try this now. Yes, okay. Sorry about that. I thought by having it up early, that would be a good thing. But so I have no conflicts of interest, and I am going to talk about reproductive health issues in patients with juvenile inflammatory arthritis. So when I talk about reproductive health, the things that I'd like to cover today will be sexuality, contraception, fertility, and pregnancy and breastfeeding. In terms of sexuality, is this an important issue for our inflammatory arthritis patients? Well, yes, I think that most people would agree that it is. And studies have actually looked at this question for arthritis patients as well as other patients with rheumatology disorders. And in general, if you look across the studies, anywhere from 31 to 76% of rheumatoid arthritis patients experience sexual problems due to sexual disability or diminished sex drive, as compared to anywhere from 20 to 50% in the general population. And this is reported at similar levels by both sexes. So there have been some studies that have specifically addressed this with JIA patients. The first one actually was published almost 20 years ago now. So this has been an area of interest for some time. And you can see that these patients, even then, when they were surveyed, had had their disease for a median duration of 28 years. So they were older, and they did report that JIA very much affected their body image. About half of them said that, and about half said that they felt they had disease-related sexual problems. In contrast, a much more recent study looked at sexual function in 21 female JIA patients. Their median age was 26. And these investigators used a specific questionnaire that has been validated and used across different studies. And in this group, they did not find any significant differences from controls. So I think that while it may be a problem, it isn't necessarily a problem, and it very much will depend on the specific patient, how long they've had their disease, and most likely how well they've been able to control their disease. And we'll talk about that in a minute. So in terms of sexual function, we really are talking about a number of different factors: sexual disability, that may be physical joint limitation, lack of mobility or pain, painful sex due to vaginal dryness, and some people do have what we call a secondary Sjogren's syndrome, with dryness of eyes and mouth, and sometimes vaginal dryness. Disease-related fatigue is an important factor, and then reduced sex drive, whether because of the disease itself, the medications, depression or anxiety, or perhaps a negative body image. So I took this from a recent publication looking at reproductive health in all patients with rheumatic disease. And I thought it was interesting in that although it's supposed to cover all of reproductive health, actually most of these factors are the ones that we've just talked about, psychological factors, sexual dysfunction, medication effects, and disease-related symptoms. There are obviously other factors that more specifically affect other reproductive health issues, such as pregnancy. But overall, all of these affect sexuality and ultimately long-term reproductive health. So what can we do about this? It's often a neglected area. And this is a study that was done a number of years ago in an outpatient center, and they surveyed physicians, nurses, and therapists and found that most of them agreed that they were unlikely to discuss sexual issues. They were not trained to discuss sexual issues. However, most all of them agreed that that should be a part of the holistic care of the patients. So I think that, an important point is to not be afraid to discuss these issues with physicians, therapists, psychiatrists, and in terms of specific recommendations on how to improve sexual function, just based on some of the factors that seem important, we should optimize the conditions that are modifiable. So certainly better control of disease, because it really does seem, again, in a number of studies, that patients who have inactive or less active disease have less sexual difficulties than those who are dealing with more active, longer-term disease. Physical therapy can be helpful, and even surgery. Believe it or not, in the 80s, there was a paper published that I cite here in an orthopedics journal that looked at the effect of a total hip replacement on sexual disability due to hip involvement in patients with rheumatoid arthritis. And they found that 50% of patients reported less sexual disability after the surgery. That was the oldest paper I found, actually, looking at this issue in arthritis patients. Also, use of lubricants for vaginal dryness, if that is an issue. And finally, and very importantly, address mood and body image issues with whomever you feel most comfortable talking about this with, because it really can have a huge impact. Well, let me move on to our next topic, which is contraception. And it is an important question, I think, for all rheumatology patients. And the question becomes, what types of contraceptives do we recommend, which are safe and effective specifically for women with inflammatory arthritis? And it's important because women with inflammatory arthritis, as with women in general, may wish to avoid unplanned pregnancy at a particular time. But also the use of medications that may cause birth defects is not uncommon in our patients, specifically methotrexate and leflunomide. Those are prescription medications that we do not want our patients taking during the course of a pregnancy. So we need to protect patients from pregnancy when they're on these meds. And then finally, active disease can actually impact the pregnancy experience and outcome. So ideally, we recommend that patients wait for a period of disease that's quiet, or at least low level of disease activity, before they plan to conceive. So we know from a lot of studies that have been done over the past 20 years or so that women who have chronic medical problems, including our rheumatology patients, they seem to be less likely to use the more effective forms of contraception. And I show you this study it's a large database study. They looked at 3 years worth of insurance claims for women in the state of Michigan, reproductive age, and they looked to see two things. Which of those women had a chronic medical condition, and that included high blood pressure, asthma, thyroid, diabetes, rheumatoid arthritis, inflammatory bowel disease, and lupus. And then they looked to see which women had been prescribed a prescription contraception. So that means usually a birth control pill, an IUD, an implant, things that you need to get through your doctor. So of all of the women, 16% had at least one chronic condition of those listed above. And when they looked to see who was getting a prescription for effective contraception, 33% of the women with chronic disease got the prescription, while 41% of those without chronic disease got the prescription. And that was a significant difference. And when they broke it down by disease, by the type of chronic condition, rheumatoid arthritis and systemic lupus had the lowest prescription rates at 20% and 21.7%. So despite the fact that there's really a greater risk for negative outcomes with an unplanned pregnancy if a woman has an underlying medical condition, these women are less likely to receive prescription contraception. And this has been documented in rheumatology patients as well. On average, 1 in 4 rheumatic disease patients at risk for pregnancy does not use consistent contraception. And these are a couple of studies that have demonstrated that over the years. The first is a survey study where women, even when aware of the fact that the medicine they were taking had the potential to cause birth defects, they were not more likely to be using effective contraception. And similarly, another database study where they pull all of this data from the electronic database, they also found that women using teratogenic medications were not necessarily using prescription contraception more frequently. So why would this be? Is there some decreased attention to contraception for women with rheumatic disorders? This study, done a number of years ago, tried to address that. It was actually done in an adolescent rheumatology clinic. So these were young adult patients or teenagers, and they surveyed the physicians to see why they weren't screening their patients. And the major barrier listed was a lack of time. Other factors, though, included discomfort with the subject area because they are rheumatologists, they're not gynecologists, and also ambivalence about the role of the rheumatologist in behavior screening. In other words, it's not my job. So I put these two studies up just to make 2 points. These are back-to-back studies that were published last year, and they were interview studies. The first interviewed patients, the second interviewed rheumatologists. So my first point is that we as a group in rheumatology are interested in and pursuing the issue of sexual and reproductive health care in our patients. And a lot of work is being done, not just to study what's happening, but to find out what patients think and what we can do differently. The other point I wanted to make with this slide, I've put in the boxes. The first is that in the top study where women with rheumatic diseases were interviewed, they actually said that their most important thing was that they wanted a discussion about this initiated by their rheumatologist. If you look at the other study, the rheumatologists, though, believe that the patient should be initiating the conversation and that if the patient wants to talk about it, they will, which we know is not necessarily the case in the middle of a busy visit. So let's talk a little bit about the contraceptives themselves. You know, overall, we want them to be effective and safe. And in general, for all patients with rheumatology disorders or rheumatic diseases, we recommend something called LARC, long-acting reversible contraceptives. And those include IUDs, whether the progesterone-containing one or the copper one, and also the subdermal implant, which contains a kind of progestin and it's implanted in the upper arm on this part of the arm. So the perfect use and real world use are closest for these methods, meaning the theoretic use is almost the same as what we see in real patients. And, in a study that compared these to birth control pills, they found that the rate of pregnancy in women randomized to one or the other was 0.27 for the LARC versus 4.55 for birth control pills. And that's because people can forget to take their birth control pill and skip a day. And obviously it's not been as effective as it would be with, quote, perfect use. And in fact, IUDs are absolutely indicated for adolescents. And the American Academy of Pediatrics recommends LARC as their first line form of contraception for adolescents who are sexually active. So this is a slide showing pregnancy rates at 1 year. And again, just making the point, here is the condom. Up here is the pill, the patch, the ring. These are all estrogen and progesterone combined. And here is LARC. So the chance of becoming pregnant over the course of 1 year using the implant or the IUD is less than 1 in 100, whereas it's about 1 in 10 or 1 in 20 for birth control pills and about 1 in 5 for condoms. So how do we choose? Well, I've shown you which are the most effective. We want to make sure that they are also safe. And for patients with inflammatory arthritis, really all of the different methods we've talked about are safe. This published review looked specifically at safety and did find that any of these methods were fine. They did not, interestingly, find a pattern of improvement or worsening of RA symptoms on the different contraceptives, because that's a whole nother issue. There are those who believe that oral contraceptive pills might improve RA disease activity, but it has not been proven in studies to date. And then I do want to mention for those in the audience who may not have JIA, but may have systemic lupus, estrogen-containing contraceptives like the pill are safe if one has a low level of disease activity, and we tend to avoid it if the disease is active. The other important subcategory is those patients who might have antiphospholipid antibodies. These are found in about 1/3 of patients with lupus. They're very rarely found in patients with rheumatoid arthritis or JIA. But if one does have this particular type of autoantibody, then they have to avoid estrogen because the antibody increases risk of blood clots, and the estrogen would further increase that risk. This is just a quick summary, so that really all of these methods have their pluses and minuses. And again, in terms of efficacy and ease of use, we do recommend the LARC. One final point about contraception is that there is emergency contraception that one can buy over the counter now, and that is oral levonorgestrel. It's a kind of progesterone, and it is pretty effective if you take it within 72 hours of unprotected sex. The other two options listed here are prescription or physician dependent, but this is easy, over the counter, and effective. And even people who are at risk of blood clots or cardiovascular disease can take this over the counter, protective pill. So let's talk for a minute about fertility. It is another important area for all of our patients with rheumatologic disease. And you can imagine that there are many reasons that fertility would be an issue and might be affected in women who have rheumatoid arthritis. Family size clearly depends on more than one's biological fertility. So these authors surveyed a number of women with rheumatoid arthritis. 91% of them had had at least one pregnancy at the time of the survey. and most of those had had a successful live birth. They talked about factors that they found to be important. So having no children, which is what they call being nulliparous, that was more common in rheumatoid arthritis patients overall compared to the general population. The number of children tended to be less. Women who were diagnosed with their arthritis before they had their first child tended to have the fewest children. 8% of patients said that their doctor advised them to limit their family size, and 20% said that their rheumatoid arthritis definitely had a negative effect on their decisions about childbearing. And what are the reasons for fewer children? Well, we go back to what we talked about with sexuality. Intercourse may be painful or difficult, and decreased desire or frequency of intercourse will obviously impact the likelihood of pregnancy. Medication effects may also impact sex drive or fertility. Having to take drugs that can cause birth defects to control one's disease means that you really can't get pregnant during that period of time. So that's a very important factor for a lot of women. Concern about one's ability to care for a child if one has very active or uncontrolled arthritis. And then even the concern about passing the disease on to the child. As unlikely as that is, it is a significant concern for many women. So let's talk about true fertility in rheumatoid arthritis and the factors that might impact that, because there are studies that suggest that women with rheumatoid arthritis take a bit longer to get pregnant when they are trying to get pregnant. So that may be in part age related, since we know fertility declines after age 35. And, a lot of our rheumatology patients postpone pregnancy because of active disease or medications. It may be that the disease itself causes some decrease in what they call ovarian reserve, meaning the number and the quality of eggs. And studies looking at this have been really conflicting. We don't know. Lower levels of testosterone have been reported in males with RA, and those levels improved after effective control of disease. There may be an effect of just generalized systemic inflammation from the RA that may impact things. And then obviously medications may have effects. So when I talked about this fertility impact, they call it subfertility, and it means that it takes longer to get pregnant. So the time to pregnancy, the TTP, has been shown to be longer in women with rheumatoid arthritis. And they found in the first study, which was in Denmark, that 25% of women with RA were not pregnant after 12 months versus 15.6% of controls. And then an even more interesting study showed again that there was an increase in TTP in women with rheumatoid arthritis, and did a good job of trying to figure out what factors were causing this increase in TTP. So they looked at 245 women with rheumatoid arthritis. They found that on average, their patients took greater than 12 months to get pregnant, 42% of the patients, as opposed to 20% of the population. And this is important because, you know that when you're trying to conceive, you can't necessarily be taking all of your medications. So that can lead to a period of time when disease is not optimally controlled. Here are the risk factors they found for prolonged TTP. Age, well, that makes sense. That's true for everybody. Never having had children before. Disease activity as measured by one of these validated, scoring instruments that rheumatologists use, the DAS-28. Using nonsteroidal anti-inflammatory agents before and during the time you're trying to become pregnant, and being on 7.5 milligrams or more of prednisone during that period as well. And interestingly, they did not find any association with history of methotrexate use, which had been a question in the past, cigarette smoking, duration of disease, or presence of rheumatoid factor or CCP antibody. And this was really the first study to identify disease activity in rheumatoid arthritis as a factor in fertility for these patients. What about medication effects? Well, prednisone can affect fertility when taken in high doses. It interacts with the normal hormone feedback loops and can interfere with ovulation. And similarly, anti inflammatory drugs, and all of them can do this, can cause something that is called luteinized unruptured follicle syndrome because of the mechanism of these drugs, where they inhibit COX enzymes. So, what happens is if one is on this drug, the follicle that enlarges and is supposed to rupture and release an egg at the time of ovulation during the menstrual cycle doesn't rupture. And so the egg is never released. Obviously, if the egg is never released, a woman's not going to get pregnant during that menstrual cycle. So this has been shown to be present in a proportion of patients. It's not clear really how strong an impact it has, but it's something to be aware of. And certainly for patients who are having trouble conceiving, stopping their NSAID, would be an easy thing to do. Finally, methotrexate, as I mentioned, sometimes there have been concerns in past years about impact on fertility, but it does not impact male or female fertility. It cannot, however, safely be taken during pregnancy. So it doesn't hurt the ovaries, but it can hurt a developing fetus. We'll talk about that in a couple of minutes. I wanted to talk about something we call assisted reproductive technology, or ART. And basically, that is what the reproductive endocrine and infertility doctors do. Whether with the use of medication or procedures, they have a number of things that they can try to help women conceive who have been unable to conceive naturally. So in general, that means that they will give medications that cause ovarian stimulation. And it may include what most people are familiar with as IVF, and then embryo transfer. In other words, taking the egg out, fertilizing it in vitro or in the lab, and then transferring it back to the woman. There are some important risks in relation to the elevated estrogen levels. Those include blood clots and risk of disease flare in lupus patients or APL patients, antiphospholipid antibody. These do not seem to be significant risks for patients who have inflammatory arthritis, but we still feel that all of these procedures should be planned for patients who have stable disease. Finally, oocytes, or the eggs, or fertilized eggs, which are embryos, can be frozen and then used by the patient later, or even by a surrogate. So these are all options and things that these reproductive medicine doctors do. What about freezing embryos or eggs in our patients? Well, again, egg freezing has become more and more popular since 2014, when the FDA said it was no longer an experimental technique. So a lot of young women are thinking about freezing their eggs, in general. I mean, irrespective of any underlying health issues or diagnosis, because it is one way of extending one's fertility. And it is something that had never been available before. So again, we feel this is, safe and effective for our patients. We check for disease stability. If patients have that antibody I talked about, antiphospholipid antibody, they will be treated with heparin, which is a blood thinner. The rheumatologist should coordinate care with the reproductive medicine MD in terms of both medications and the procedure itself. If one is freezing eggs for later use, unless a patient is on cyclophosphamide, which thankfully we hardly ever use anymore, it is okay to continue one's medications, because remember, many medications interfere with the development of an embryo, but very few medications affect an egg. One that does is the cyclophosphamide. if pregnancy is planned, though, of course, you have to change to medicines that are compatible with pregnancy. So in the last, 15 minutes or so, I'd like to go over some of the important messages that we have for our patients about pregnancy. And I think the first and the most important message is that patients with rheumatic diseases, really any rheumatic disease, should have a pre-pregnancy evaluation. So this is something that should be discussed with the rheumatologist in addition to the OBGYN before attempting to conceive. And there are a lot of reasons for that. This is my flow chart of how we approach a patient with a rheumatology disorder, whether lupus or inflammatory arthritis or any of the others, because the steps are really the same, whatever the underlying diagnosis. The first thing is that we assess disease severity or damage. That is most common in diseases like systemic lupus or some kinds of vasculitis. Very, very unlikely in patients with inflammatory arthritis. But in our other patients, if there is something like near end stage kidney disease, for example, then we recommend either IVF or postponing pregnancy until after a renal transplant or considering adoption. Because although very rare, we do have some patients who have such damage from their autoimmune disease that pregnancy would be life-threatening for them. So for most patients, we're starting here, assess disease activity. And we like the disease activity to be inactive for a number of months. And if disease is active, we treat to control and defer pregnancy before circling back to assess the medications. So medications sort of fall into three groups: those that have been demonstrated to be compatible or safe for pregnancy, those that have been demonstrated to be clearly unsafe for pregnancy, and the third group is those that we just don't know. And in that group are many drugs that have been released in recent years, so they're fairly new. So if someone is on medicines that are contraindicated, we either taper them off and observe them, or if that's not possible, we change to a medicine that we consider low risk. And then at that point, we assess other factors. We look for antiphospholipid antibodies. We look for anti-SSA or Rho antibodies, which I'll talk about in a minute. And we also, particularly in patients with inflammatory arthritis, check their neck range of motion and hip range of motion, because we want to know the status of those joints in advance of the time for delivery. And so after we go through these various factors, we counsel the patient and her partner regarding the risks and the recommendations so that they will know what to expect, what we recommend, and how to move forward. So pregnancy in rheumatoid arthritis patients tends to be really overall a very smooth process in comparison to some of the other rheumatology disorders. And in fact, it's been long known that there is a beneficial effect of pregnancy on rheumatoid arthritis disease activity. And this was first noted back in the early 80s. That report estimated that 3/4 of patients had some degree of pregnancy-induced remission, most of them able to stop their meds. But in general, they all had a postpartum relapse of their disease activity by 6 weeks to 6 months. And half of these remissions occurred early in the first trimester. So in more recent years, with more stringent measurements of disease activity, we see that, yes, it is true that a lot of women will have a pregnancy-induced remission, but it's probably more like 50%. And again, those women will almost always flare postpartum. Interestingly, seronegative patients, meaning those who have rheumatoid arthritis but do not have a positive rheumatoid factor or CCP, in this study from 2010 were more likely to improve during pregnancy than those who had the autoantibodies. Pregnancy outcomes in patients with rheumatoid arthritis are generally very good. Well-controlled patients have outcomes that are the same as the general population. There is a very slight risk of a lower birth weight or preterm delivery and more frequent cesarean section. And this seems to be related to disease activity and potentially to prednisone use during the pregnancy. There are some recent studies that have focused specifically on pregnancy in women with JIA. And overall, the results are, again, I think very reassuring. This study looked at women and men, and they found no differences between those treated with disease-modifying medications during the pregnancy, obviously ones that had been felt safe, and non-treated patients. There was no increase in birth defects. There was a small increase in preterm birth and an increase in C-sections, cesarean sections. And they did not find much of an increase in disease activity in women during the pregnancy. And then this study similarly was pretty reassuring. They looked at JIA patients and they broke down their group of patients into those who had had pediatric JIA but no longer had active arthritis, and those who had arthritis that persisted into adulthood. Overall, there was a very slight increased risk for preterm birth, and in those who had ongoing active arthritis still, a slight increased risk for small for gestational age, babies, and preeclampsia. But the risk really was quite small and not anywhere near the risk that we see, for example, in our patients with systemic lupus or antiphospholipid antibody. So overall, we continue medications that are compatible if needed, but if they're not needed, we'll taper and stop. We follow carefully for evidence of a flare, and importantly, have a plan in place for the expected postpartum flare. And I told you already, we check joints ahead of time. If someone's having a cesarean section and they've been on chronic steroid, we may consider prophylactic stress dose steroids at the time of the surgery, and also prophylactic antibiotics if someone has joint replacements. Again, although I know it's a small proportion of the audience, I think there are important issues, as I've alluded to, regarding pregnancy in patients with lupus and or antiphospholipid antibodies. So I thought I would just mention that our lupus patients do have a higher risk of adverse pregnancy outcomes. That fetal loss, preterm delivery, small babies, preeclampsia are all increased, and that the risk factors for these negative outcomes are primarily having active disease when conceiving, having antiphospholipid antibodies, or having a history of or current active kidney disease, lupus nephritis. For those who have the antiphospholipid antibodies, we often will treat with blood thinners during pregnancy, and of course with increased monitoring. Now, I told you that we check patients for anti-SSA Rho antibodies and the companion antibody, which is called SSB-LA. And these antibodies, it's SS because it stands for Sjogren's syndrome, and they are actually most common in patients who have Sjogren's syndrome. About 3/4 of them will have these antibodies. But about 1/4 of patients with rheumatoid arthritis will also have these antibodies, and 1/3 of patients with lupus. And they really are important only in pregnancy. And that is because these antibodies can cross the placenta and reach the developing fetus and cause inflammation in the fetus. And the risk of that in a woman who has high levels of these antibodies is 20%, although the most serious complication, which is complete heart block, occurs in only 2%. Mortality in that case is 20%, and most of those babies require pacemakers. The manifestations that can occur and then resolve include rash, liver function test abnormalities, and low blood counts. So our recommendations for women with these antibodies are to monitor them with fetal echocardiograms that look at the baby's heart rhythm. And if there is an abnormality, we may treat them with a form of corticosteroid. We also recommend that our patients with these antibodies take hydroxychloroquine during their pregnancy because several recent studies show that of all the medicines that we have studied, hydroxychloroquine is the one that seems to be protective against the development of heart block. So odds ratio of 0.23. So that means that instead of a 2% risk, it becomes something like a 0.5% risk. So we feel that that is important as prophylactic therapy. And then, as I mentioned, we may try corticosteroids if there's early heart block. But if it's complete heart block, we don't do that. We just plan for a pacemaker. So this is a very, very rare complication. And I mention it because it is one where we can predict who is at risk for it, even though it's a small, small number of those babies. That's why we do the monitoring. And in our last few minutes, I do want to talk about medication use because that's one of the most important issues for pregnancy, especially, I think, in women with inflammatory arthritis. So it's important to talk about it again, preconception. If you're taking something that is not safe for pregnancy, we switch. And we don't just switch, but we make sure over the course of several months that the new medicine also controls one's arthritis and that there aren't any side effects that would preclude being able to continue it during a pregnancy. If there is accidental exposure to medications that are teratogenic, meaning those that could cause birth defects, obviously we stop the medicine immediately. And there are genetic specialists who work with high-risk OBs who can counsel someone about the risk for them, that is, how likely it is that this particular drug taken at the particular time it was taken would cause a birth defect. And then finally, we do encourage our patients to breastfeed if desired, and many of our medications are felt to be safe during breastfeeding. So when you think about the use of medication during pregnancy, you can imagine, our major concern, of course, is risk to the developing fetus. And that risk depends on both how much of the drug is transferred across the placenta, and also when in pregnancy the drug is given. So some drugs will cross unchanged, but some may be metabolized or changed by placental enzymes into an inactive drug. That's the case for prednisone. So when we give prednisone, it's a very small proportion of the dose we give to the mother that crosses the placenta in an active form to reach the developing fetus. And the timing is important because birth defects most commonly occur when a drug is given during the first trimester. But the degree of transfer across the placenta can also change during pregnancy. For example, and this is important for women who are taking commonly used arthritis medications like TNF inhibitors, that is an IgG antibody. And that transfer doesn't begin until 16 weeks. And it gets greater and greater until it reaches its peak rate of transfer in the third trimester. So this is our list of medications. Not all of these are relevant to every patient, obviously, but I told you that we put them into really three groups. So as you see, hydroxychloroquine, sulfasalazine, NSAIDs can be taken at certain times, prednisone, TNF inhibitors, and then some other drugs that are used for other types of rheumatic disease, azathioprine, cyclosporin, tacrolimus, IVIG. Those are all drugs that we feel comfortable using. We avoid at all costs use of drugs that are known to cause birth defects, and that's these four: cyclophosphamide, mycophenolate, methotrexate, and leflunomide. And then the others I mentioned really have unknown risk. It isn't that we know that they would do a bad thing, it's just that we really don't have enough information yet to know one way or the other. And that includes non-TNF inhibitor biologic medications. And it includes the novel small molecule medications like the JAK kinase inhibitors. Although I would point out that those are very low molecular weight. So in theory, it's likely that they will pass through the placenta. So I mentioned the issue with anti-inflammatory drugs with stopping the follicle from rupturing and releasing the egg. There's also a controversial question of increased risk of miscarriage. And finally, and most importantly, we cannot use these medications, ibuprofen, naproxen, in the third trimester because that is harmful to the fetus. It causes closure of a small duct that then affects the fetal heart and lung circulation in a negative way. Methotrexate clearly causes birth defects and miscarriage. We don't know exactly how long before conception it needs to be stopped. We usually say 3 months. One study suggested that there's really not a big increased risk if it's taken pre-conception but not post-conception, and that's this study that I cite here. Now, to me, the importance of this study is that if a woman is taking methotrexate, stops, and becomes pregnant the next month, this study suggests that she does not need to worry about birth defects, but it's in no way meant to encourage women to stop the methotrexate at the time they conceive. But it's reassuring if that situation comes up. And this slide shows another reassuring study, similar idea for leflunomide. So one thing you may know about leflunomide is that it has a very, very long half-life in the body. In fact, the half-life is about 2 years. So because we have concerns about it causing birth defects, if a woman has been on it within the past 2 years, and certainly if on it at the time she conceives, we don't just stop the drug, but we treat with cholestyramine, which is something that binds the drug. And we call this a washout. Obviously, refer for genetics counseling. The washout is actually pretty intense. It's 3 times a day for 11 days, and then check the metabolite level, that is the active drug level, 2 weeks after you finish. Just like the methotrexate study I showed you, this study basically said that if a woman accidentally became pregnant, realized it immediately, took cholestyramine, the chances of having a birth defect was very low. So again, not to encourage people to stay on this medication, but just in case, it's important information to have if there is accidental exposure when making a decision about what to do going forward. TNF inhibitors can be used safely at least until the end of the second trimester and probably through the whole pregnancy. Most of the studies come actually from patients who have inflammatory bowel disease because they often need to be on it for 3 trimesters. So this is just a series of facts about TNF inhibitors, but they're really all reassuring. And the bottom line is that we continue it as long as the patient needs it. We try to stop it at 30 weeks if possible, because the placental transfer goes up a lot at that point, except for certolizumab, which does not cross the placenta. And if one needs to be on this drug for the whole of the pregnancy, we just suggest not giving the rotavirus vaccine because that is a live vaccine. And we wouldn't want to take a chance of giving a live vaccine to a baby that may be immunosuppressed from the drug. For lupus patients, we have different medicines and different ways of adjusting them, but we basically do the same thing. We take mycophenolate, commonly used, change to azathioprine. If that doesn't control disease, we will then go to a drug called tacrolimus. And there are studies that suggest that this works well, and we've all done it in many of our patients with good results. This is our last topic, breastfeeding. And again, 3 groups of drugs, but you'll see that biologics other than TNF inhibitors are felt to be safe to take during breastfeeding. Still can't take methotrexate or leflunomide, and then the small molecules are unknown. So in summary, I think we would all agree that reproductive health is a very important aspect of our rheumatology patients' health, and that includes effective and safe contraception to prevent pregnancy when it's not a good idea and to help plan pregnancy during an optimal time. Fertility methods and procedures can absolutely be used successfully. Just important to have communication with the rheumatologist and the fertility doctor. And then our medicines, although not every medicine can be used during or after pregnancy, many of them can be. And so that allows us to do what we really aim for, and that is to control the mother's disease activity in the safest way so she has a successful pregnancy with a healthy baby. So I will stop sharing my screen now, and I'm happy to take any questions if there were some that came in.
There sure were. So I'm going to ask some of the questions that we had come in during the session. So one of the questions was, has there been any studies to know if there is a possibility of passing on our disease to our children?
So, I did mention that briefly, and I think that yes, there have been studies, and for the most part, it is very unlikely, but it is still a little bit more likely than if a woman did not have inflammatory arthritis. So, JIA, RA, lupus, these are disorders that are not true genetic disorders, the way cystic fibrosis is, for example, or I don't know, thalassemia. There are genetic disorders where you can trace it through the family tree and you can say that your child will have a 25% chance or whatever, depending on the partner's genetics. But for our patients, it's just a lot more complicated because we don't think there is one single thing that predicts who will develop one of our diseases. We know that genetics makes a difference in terms of like the type of immune system that one inherits. So some immune systems are just more likely to get overactivated and have trouble settling down again. So if you inherit that kind of immune system and you are also exposed to environmental things that, are important in development of arthritis, then it makes sense to think that your children may also have that, reactive kind of immune system. So they may also be a little bit more likely. But the numbers are very small. And honestly, we rightly reassure our patients that it's unlikely that their children will develop the same disorder. Obviously, a pediatrician needs to be aware of the family history, just as for any disorder, because there are a lot of things that can run in families. So I would think of this as maybe being able to run in a family, but not being inherited per se.
Great. Let me ask the next question. So I guess in summary, what would be the major steps that you should take if before trying to get pregnant with RA? In, I guess, considering like finding different doctors and things like that, what should people be doing in order to prepare?
Okay, so that's a great question. And I think that if you are thinking about it in the near term, then I think it is useful to identify, of course, an OBGYN. And, although it isn't absolutely necessary, a number of our RA patients will go with a high risk OB or a maternal fetal medicine doctor, just because those doctors, those OBs have extra training in maternal or mother's medical issues. So they're just more like on the alert for things. So I think personally that it's a good thing to do, whether you have high blood pressure or RA or lupus or asthma. So that's one thing to do, to sort of research and identify someone. The next thing, and I had said this as like my number one message, discuss it with your rheumatologist. So, I didn't go into this during the talk, but last year we published something called a reproductive health guideline with the ACR, the American College of Rheumatology. And the goal of this was to take all of the literature in this area, have it evaluated by experts, and come up with recommendations for rheumatologists as far as how to counsel their patients, how to treat their patients. And we covered all of these different topics. We had a focus group before we did our voting with patients. And the number one message from the patients was that they wanted to be able to talk to their rheumatologist about these issues early and often. So when I meet a new patient, I mean, I may not do it the very first visit, depending on what's going on, but certainly if not then, and by the next visit, I ask about plans for pregnancy or thoughts about pregnancy. And I always preface it by saying this may not be relevant to you now or ever, but, and then this way it opens up the conversation so that early on someone can say, you know, I am worried about it, but I wouldn't want to have a baby for maybe 5 years, but you know, will my disease make a difference? Will my meds make a difference? So if you start talking about it early, I think it's reassuring because then you know what to expect. And then once the time comes closer, you need to do those steps that I sort of outlined in my little flow chart. And for patients with rheumatoid arthritis, for the most part, it's medicine, 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 you know, because as I said, damage issues not usually seen. So it's looking at one's medicine and figuring out what to do with the current medicines if they're not safe for pregnancy. So a common scenario would be a woman who's on methotrexate and one of the TNF inhibitors. You know, what does this person do? Well, what we usually will do is stop the methotrexate 3 months before planning to start trying and continue the TNF inhibitor and hope that that's good enough to control disease. If it's not, we need to think again. Usually it is, unless it takes a very long time to get pregnant. And then once someone is pregnant, we think about, should we continue the TNF inhibitor or should we stop it? Should we continue it through the first trimester? Because none of it is reaching the fetus at that point because it is an IgG and it can't cross through yet. Or should we stop it early on? I tend to continue during the first trimester into the second trimester. And if things are quiet, often what I'll do is like taper it off, you know, just to make sure so someone doesn't have a big flare. And that's usually successful. And studies have shown that to be a good way to do it. So women who stayed on their TNF inhibitors till say 20 weeks and then came off were not likely to have a flare afterwards. And if someone does need it the whole time, as I mentioned, then we go back and, you know, counsel them about the potential for a decreased immune, you know, response in the baby and avoiding things like, you know, live vaccines, which I mean, really rotavirus is the only one in the US. But there's been a lot of study of that too, as I mentioned, from the inflammatory bowel disease patients who most of them have to stay on it through the third trimester. And they have found that their babies are not more prone to getting infections after birth. And that when they get their regular vaccines, they respond properly. You know, they make the right antibodies. So really, you know, it seems to be very low risk. So I think talking to your rheumatologist is the most important thing you can do because they may not bring it up with you if they're not thinking about it. So part of what we're trying to do with this guideline that we published last year and with other educational programs for rheumatologists is just sort of encourage them to think about this as another facet of your patient's health, which it is. And, you know, rheumatologists follow their patients usually for a long time. And, you know, we see our patients pretty often. You may go to the OBGYN once a year if you're not, you know, pregnant or thinking of getting pregnant, but you probably see your rheumatologist more often than that. So I think in terms of planning, you know, you should think about it maybe a year in advance so you can think about how to change meds, but otherwise just, you know, have it be an ongoing conversation with your doctor.
Great. I also, once we're done, I'm going to show everyone that we did link the guideline that you keep mentioning in the app. So I'll show everybody how to find it so that you can reference it on your own. And then just one more question for you. One of the slides indicated that postpartum flare-ups were likely to occur within 6 weeks to 6 months of birth. Does breastfeeding change the likelihood of flares or extend the time period for flares?
Another good question. And studies have looked at it, but there's no consensus. So I think it does not. But it's a commonly asked question. But I think that the studies that have been done suggest that it doesn't seem to influence it. And we don't really know what influences it. So, I didn't go into detail about this. I mean, I said to have a plan in place for the flare postpartum. So for patients who've had really active arthritis before pregnancy, debilitating active arthritis, I encourage them to start back on their TNF inhibitor or other biologic, soon after they deliver. Some people don't want to do that. They understand what we're saying, that we think this is very low risk and safe to do, but they just don't want to take any chances and they don't want to be on the medication. And if that person hasn't had, the worst arthritis in the world, then in that case, sometimes, women will choose to wait. And as soon as they feel things acting up, that's when they'll start their medication. So there have been times when we've had to put them on prednisone for a brief period of time until the medication kicked in. And I guess one of the messages that reminds me of that I might not have stressed, but every person is different and the diseases are different. The meds that work for you are different. And the way you feel about things is going to be different from person to person. And that's why when it comes to contraception or to these pregnancy medication issues or breastfeeding and medication issues, it's really important to discuss because, your doctor will work out the decision with you that is right for you because people feel differently. Some people don't mind taking a risky medicine during pregnancy. Not that we like to do that, but whereas other people, there are women who are told they can take Tylenol during pregnancy and they still won't do it because it just makes them too nervous. So very important, again, like the communication and expressing your own thoughts and feelings about this, because that helps to come to the right decision for you.
Great. Okay, so thank you so much for coming to speak with us. We really appreciate it, and we've never had a talk on this before, so I'm just grateful that you were able to come and answer some of our questions. Can you guys see my screen? Let me see. With that, I don't know. I'm trying to show. Hold on. Let me X out of this PowerPoint. I just want to show everybody where that guideline is, so that everybody can find it. Let's see. Okay, so right here, if you go onto the website, right where the session is, and then the guideline is right linked down at the bottom, it'll take you right to it and everybody can review it on their own time. So thank you so much, Dr. Sammaritano. We really appreciate it.
Of course, it was my pleasure. I enjoyed it.
Great.
So, and I know you'll enjoy the rest of the conference. Wish you the best for a very successful meeting.